for the first time, mandatory sentences for drug crimes. The historical experience of the United States illustrates that getting tough on drug offenders simply stuffs prisons and jails with low-level users, many of whom show clear evidence of mental illness that, in most cases, preceded the onset of their substance abuse problems. Drug prohibition has had other consequences, too. It has produced a hardened cohort of violent young men schooled in ruthless gang violence over drug profits. And this is what has given rise to CSC's changing offender population. These young men are not necessarily mentally ill, though many of them do suffer the effects of prolonged drug abuse, but they create legitimate management problems for Correctional Services Canada. And prisons have become, in the words of one Aboriginal gang member, gladiator schools for young men as they cycle in and out of the criminal justice system. So our federal prisons have become gladiator schools where we train young men in the art of extreme violence or warehouse mentally ill people. All of this was foreseeable by anyone who cared to examine the historical experience of alcohol prohibition, but since we refuse to learn from history, we are condemned to repeat it. And that brings us to the present. I call on the federal government to engage the Mental Health Commission of Canada in the development of a national strategy that would achieve collaboration and coordination among federal, provincial, territorial, criminal justice, correctional, and mental health systems to A, promote the seamless and cost-effective delivery of services to offenders with identifiable mental disorders, and B, to initiate innovative community-based service delivery models for these offenders, and focus resources in particular on those mentally disordered offenders with co-occurring substance abuse problems who are living in disadvantaged social circumstances, a population which poses the greatest challenge for effective service delivery and social reintegration. A national strategy to address mental health in the correctional system must grapple with the reality that the great majority of persons in the correctional system suffer from concurrent disorders. They have a mental health condition as well as a substance abuse disorder, which means that both conditions have to be treated simultaneously. Now, if the government achieves its objectives, estimates are that the current population will grow by as many as 3,000 new beds for men and as many as 300 for women. These are conservative estimates because so far no one has made public the anticipated costs and consequences of the crime agenda. But we can make some general projections based on the American experience. Number one, crowding increases tension between inmates. Among the first noticeable effects of crowding is elevated blood pressure, both systolic and diastolic. Elevated blood pressure is a gateway to metabolic syndromes, including diabetes and heart disease. So the first obvious effect will be to create the conditions for chronic health conditions downstream. The second immediate effect is that crowding elevates the incidence of viral and bacterial transmission between inmates. So crowded prisons are sicker prisons. Crowded prisons are also less habitable environments because malodorous air pollutants heighten negative psychological effect and cause behavioral disturbances and depressive symptoms. Currently, the federal system is running at about 10% double bunking. No one, to my knowledge, has assessed the population health burden of the crime bills once they come into force, but it would be prudent to assume that our prisons, which are already incubators of HIV and hepatitis C, will begin to breed numerous other infectious diseases as they fill up. To my knowledge, no one has assessed the consequences of this elevated level of infectious conditions for labor requirements across the federal system. People have to work in these places too. Number two, tension increases stress levels among inmates and staff. As tension increases, staff feel less safe and limit their personal contact with inmates. They adopt a more cautious posture and keep a greater distance from inmates on the ranges. This contributes to increased tension because it creates a self-escalating cycle as staff and inmates perceived elevated anxiety in each other's nonverbal behavior. Disputes that might have been resolved with conversation take on a combative quality, and staff, in order to protect themselves, wear heavier apparel like stab-resistant vests. Behavior symptomatic of mental illness is sometimes treated in prison as a disciplinary rather than a medical problem. This cycle rapidly degrades the quality of work for staff and guards, which is an outcome that this committee should examine closely because, among other problems, it will eventually drive good correctional officers out of the profession. As CSC will admit, they already have problems attracting and retaining staff. Rapid growth in the rate of incarceration can only exacerbate this problem. 3. As stress levels rise, we can expect to see more incidents of self-harm and suicide attempts. As Alison Liebling has written, prisoner suicide is not exclusively or predominantly a psychiatric problem. There are multiple psychological pathways to suicide in prison, one of which is the social isolation that accompanies the management of a rapidly growing population. Furthermore, there are at least 3 identifiably different kinds of prison suicides in the literature: life sentence prisoners, the psychiatrically ill, and the poor copers. These latter are generally younger and non-violent, which is exactly the population that will be caught up in this new binge. Liebling claims that women far outnumber men in terms of incidence of self-injury per head of population, as up to as many as 1.5 incidents per week per woman, and that 20 or 30 incidents of cutting during one sentence is not unusual among women prisoners. 4th, elevated stress correlates with population management problems. As populations become harder to manage and control, staff turn to segregation and other forms of offender control, and invariably these fall disproportionately on those least able to cope with the pace of change and who act out of desperation and frustration. Again, symptoms of mental disorder manifest as behavioral misconduct which are disruptive to the good order of the institution, and mentally ill persons find themselves singled out for special, usually harsher treatment, but also for the hostile attention of other inmates. So crowding turns into elevated stress, which turns into heightened tension, which manifests as violence. I'm going to conclude now. If the government is committed to growing Canada's rate of incarceration, it will impose great costs on the correctional system in the short term, costs which will be felt in the safe management of the population, in staff and inmate stress levels, and in the overall incidence of violence. The service will have to fill many vacancies in its therapeutic complement, social workers, psychologists, and substance abuse specialists, if it wants to prevent the worst effects of overcrowding on inmates with concurrent disorders. As the correctional investigator told you, many institutions are currently not staffed, funded, or equipped to deal adequately with the needs of mentally disordered offenders. Interdisciplinary mental health teams are supposed to be on site, but in many facilities these teams exist in name only. Last point. We could be heading into a very difficult time for the service. It is urgent that the government grow the service's capacity to address these issues with the same alacrity that it seeks to grow the rate of incarceration. Thank you for your time and attention to this urgent matter.
Okay.